Okay, so kind of same idea. We get the history, we move on to the physical exam. So we've kind of focused in on the sensory branches here. If your entrapment is high in this area, you'll have loss of the dorsal and palmar aspects. And you can see here just a nice diagram showing how the hand is divided up sensory-wise in ulnar, median, and radial nerve territories. Okay, so for our purposes, a more proximal ulnar nerve lesion will have these types of deficits here. Okay, so physical exam. So a lot of different findings in ulnar neuropathy that sometimes can be a little bit confusing, so we'll try to go through some of them. This top diagram is basically a characteristic finding called a Wardenberg sign. Many patients with ulnar neuropathy will say that, I try to put my hand in my pocket, my pinky gets stuck. And some of this is unopposed radial nerve function. That's basically trying to extend the finger. And there's trouble with basically flexing that digit. Ultimately, as we said, the ulnar nerve controls the hand intrinsic muscles. So you could, when testing this, you could look at the first dorsal and interosseous muscle, trying to push the finger against the examiner. You could look at adduction, and then lumbricals 3 and 4, and we talked about 1 and 2 being median nerve. A claw hand is a term that can be referred to different, basically postures of the hand, and really depends on whether you're asking the patient to open or close the fist. So in more proximal nerve injury, there's trouble with flexion. So in this upper right picture, if you're asking the patient to make a fist, you see the median nerve innervated first and second digit are working, but the fourth one, fifth ones are not. In a more distal nerve injury, you're having trouble extending the fingers. So here we're asking the patient to open their hand, and they're having trouble doing that. Something else that's a good thing to look for is atrophy. So we talked about thenar atrophy for the median nerve. Here we're looking at hypothenar atrophy. So again, inspection is very important as part of physical exam. Some other maneuvers to be aware of. One is called Frohman's sign. So here we basically have a patient try to basically grab a piece of paper, and we want them to normally push down. If they're not able to do that, they're not able to adduct because the ulnar nerve is not working. They'll compensate by switching to flexion, and that's driven by the median nerve, which in an isolated ulnar neuropathy, the median nerve should be working. So I think that's pretty well demonstrated in this cartoon here, normal, and Frohman's positive. You could also see in this picture that there's wasting of the first dorsal interosseous space. So that's basically the space here between the thumb and index finger. Okay, and this is one that you may hear about. Other maneuvers, you could look for a Tinel sign over the cubital tunnel. So striking the medial aspect of the elbow where the nerve is located, you'll cause a shock-like sensation going down the arm that may reproduce the patient's symptoms. In very slender people, you're able to feel the ulnar nerve pretty well at that area. Basically, in all patients, I do make an attempt to feel the nerve because in some patients, the nerve will sublux or actually dislocate, passing over the medial epicondyle. If this happens, you can imagine if this is occurring repetitively, you could develop a pseudoneuroma or irritation along the nerve at this site. And if that's detected either preoperatively or intraoperatively, rather than simply decompressing the nerve, we'll do what's called a transposition, where we move the nerve to a new spot rather than having it get injured repetitively at its original location. So ultrasound is, in patients that have a larger body habitus where I can't feel the nerve, I will usually get an ultrasound to assess for any subluxation or dislocation. And it's also helpful to look for any swelling, again, proximal to the entrapment, like we looked at in those pictures for carpal tunnel syndrome. And then, of course, electrical studies, you could see focal slowing across the elbow. Just like we talked about for the common peroneal nerve, you could measure the speed along the ulnar nerve above and then below the elbow, so below the site of entrapment, and look for sometimes drastic slowing that occurs more distally. I should mention also that people have studied this with what are called inching studies, where you can really try to localize the site of compression. Okay, so differential diagnosis, again, you want to think broadly in evaluating these patients. Another somewhat less common, but well-recognized entrapment site is at Guillen's canal. So this is here at the level of the wrist. This abuts the carpal tunnel. Basically, this is very common in bikers who are, bicyclists who are on where this part of their hand is against the handlebar for, for hours or more. Here, if we think back to those sensory diagrams, you'll have loss of sensation in these regions. You may have a Tinel sign in this area. And then again, electrical studies and imaging can be helpful. Since it's a little bit less common, always recommend an imaging study. There could be a ganglion cyst present or other pathology. Thoracic outlet. In these cases, patients commonly complain of pain with overhead movement. The pain is usually somewhat diffuse. There's an entity called the Gilyot-Sumner hand where there's atrophy of both the muscles innervated by the median and ulnar nerve. Very, very rare to have this true neurogenic form. Others have this more kind of aching pain with preserved neurologic function. Many times there are structural entities such as a elongated transverse process of C7 or a cervical rib that can impinge in the thoracic outlet, which again is an anatomic space where the brachial plexus travels. And just like carpal tunnel, there's basically narrowing and pressure or compression along these natural paths of the nerve. So many times, let's say with a cervical rib, the lower portion or inferior portion of the brachial plexus is irritated, and that provides, basically turns into the ulnar nerve more distally. So something else to think about in examining someone you think has ulnar neuropathy. And then of course, cervical radiculopathy, just like we talked about for the median nerve. These patients will probably have neck pain, pain going down the arm. And the studies we discussed apply here as well to the ulnar nerve.
Hey everyone, Ryan Rad here from neurosurgerytraining.org. If you like that video, subscribe and donate to keep our content available for medical students across the world.